Today we have a guest speaker, Dominic Dwyer, Data Access Officer at Public Health England. Dom will be speaking about how biobanks can link their samples to cancer registries in England for easier access to data about diagnoses and treatment information. We feel this could be an excellent opportunity for biobanks to have access to data that may be very hard for you to collect otherwise. As many of you know, in addition to curating the tissue directory, we have a coordination role. This means we stay abreast of developments in the field in order to bring them to you. We only actively do this for those of you who have registered, so your registration is a good way to ensure we can continue to bring you relevant events. As a centre, we are dedicated to ensuring that whenever possible, we remove duplication of work. So this collaboration is a good example of us working with another organisation for this purpose. You will hear today about how some of the data you need to provide to PHE in order to access their BiobankLink. We are working with them to try and ensure that whatever data you have to provide them is in the same format as that which you'd need to register with us. This means that one extraction of data from your database can have several usages. And so, for example, we are also looking at how exports that PHE provide back to you could be reused to enhance your registration in the directory. So this is all about trying to remove extra workload to bring maximum benefit to you. We will be presenting more on the data standards being developed by the Centre at our annual meeting in October, and we'll let you know more of those details at the end of the webinar. So to start off, we have a poll for you to answer. Just come up here. So we were interested in hearing about what your interest is in today's topic. So are you here for general information, information more related to your operations, use of your service for your own research, or use of the service to support others' research? Okay, I think that's everyone. And so we have another poll. So we want to know, how do you currently collect disease and treatment information? So do you use manual methods like reading notes, electronic health record downloading, PHE Cancer registries in the past? Okay, and I think we have one more. Do you struggle obtaining clinical data on the samples you hold currently? So this is just a yes or no. Okay, great. I think that's almost everyone. So it's now time to hand over to Dominic to start his presentation.
Okay, so hi everyone. Thank you, Emma, for the introduction. Kind of as was explained just then, yeah, the idea of today was go over something that PHE are looking to develop, and it has been in the pipeline for a little while in terms of making access to clinical data easier and more quick for biobanks, and linking the clinical data to the samples that they hold. As I said, yeah, it's been something that's been in the pipeline for a while. So this has been piloted before, and it's being picked up again. My role was actually funded through Cancer Research UK and Macmillan to try and help with access to clinical data. So I've been working with Public Health England and in the Office for Data Release team to help with access to data and to navigate through some of the information governance barriers that are in place to safeguard confidentiality and to keep data safe. But we also want to share the data as much as we want to protect it, and it's about finding that balance, and that's where I've been trying to help. So today, yeah, one of the things I was hoping we could go through would be essentially what the BiobankLink is, the sort of information we'd require from the biobanks to apply for it, the data that you could send across to us, and then the clinical data that we would return, and hopefully get some feedback around whether it's useful, if there's anything that you think might be missing, if the BiobankLink meets your needs on the whole as well, and if there's anything that we can add to it to make it even more beneficial, then that'd be really great feedback to hear. So moving on, England's has 3 large data controllers where you can get information relating to cancer. The main one being Public Health England, that have the National Cancer Registration Analysis Service. So that used to be, up until 2013, the National Cancer Registration Service and the National Cancer Intelligence Network. So you may have heard those two used in the past, but they've now combined to create an organisation that collects and analyses all of the cancer data in England. And the Office for Data Release within Public Health England acts as the front door for that. So external researchers, we don't collect the data to just sit on it. External researchers are encouraged to apply for the data, and they do so through ODR that have some processes to enable you to apply for data, and we'll cover those later. The other main data controllers would be the Office for National Statistics, or ONS, and they have a lot of the mortality data and date of death and place of death, and also NHS Digital, that has an awful lot of information on hospital episodes and also diagnostic imaging data. So to go into that with a little bit more detail, so as explained earlier, ONS have the date, cause and place of death data. NHS Digital have the hospital episode statistics, and every time you go to hospital it's recorded in that data set. The diagnostic imaging data set, which has a lot of the imaging that's recorded or performed on patients. But the main set of data we'll be talking about today would be the Cancer Outcomes and Services data set, which is a data standard that is mandated for NHS trusts treating cancer patients to fill in and to send back to PHE to create a national cancer registry. But on top of that, we collect extra data. There's a systemic anti-cancer therapy data set, or SAT. So chemotherapy information get added to the data standard. Radiotherapy information can be added to the standard, and we're also reporting information on patient experience and patient-reported outcome measures or cancer waiting times, and lung cancer audits and prostate cancer audits as well. And they can all be linked together, usually by NHS number. So clinical trialists or other people looking to apply for research data can send a data request coming into the ODR. Once it's come in, it's processed, and the information governance processes are navigated, and then you get access to the data, and it can be linked to NHS Digital as well. As a general rule of thumb, there's an understanding or memorandum of understanding between the three data controllers outlined on this slide. So rather than doing 3 different applications to get different data from each data controller, you can just send it to one, and it can get linked by that relevant data controller, so that it's only one application that you apply to. As a general rule of thumb, you should apply to the data controller that owns the majority of the data you'd be requesting. So if it's loads and loads of hospital information and maybe a stage of diagnosis or something for the cancer patients in it, that would be best served by NHS Digital. But likewise, if you wanted cancer patients, a lot of the diagnostic information, and then also some information on their hospital attendances, Public Health England would be the relevant data controller to apply to. And if you ever just want to call up the ODR or email the ODR, we'd be happy to help formulate an application and let you know the most relevant person to apply to, and if it's us, process the application as well. So yeah, the Office for Data Release is that front door that I was talking about. We have information governance processes that we work within. The common law duty of confidentiality, which I mean, a lot of these may not make much or mean much to the average person, but that essentially means for biobanks, most of the time, what I mean, do you have consent to share the information for samples and apply to the registry for it? The Data Protection Act just makes sure everything remains fair and legal, and only the minimum amount of data is requested, and it's held for a certain amount of time. And then the Caldecott principles as well, which were published by the National Data Guardian, but have been updated fairly recently. I think it was in 2013, because they wanted to stress that the duty to share was important as the duty to protect confidentiality. And then last, there's also the ICO that the ones that make sure everyone's abiding by the other principles, to make sure data is being processed in a fair, legal, and transparent way. So in terms of applying to data for this BiobankLink, it will still involve these sort of principles. And the best way to do that, if you can send through a protocol of the work you'd be doing, i.e. the biobank that you have, the research that you'd be looking to do with the data, any reason for asking for the data, and that's then used to justify the data items that you'd select. So the BiobankLink is slightly different in that regard, in that it's a set of data that we could release, and we'll go over that later. But as a more general route through the ODR, if you wanted to collect more data than is offered by the BiobankLink, that's possible as well. It would be done through a protocol, and that could essentially justify why you need the data items. If you were linking it to the samples and who knew they were, so it was essentially identifiable, we'd need to see the consent forms as well, just to make sure they're aware that they've agreed for you to do that. And then also, if it's research based, then evidence of the research ethics as well. And given it's a biobank, also the HTA license would be useful too. One thing I will mention now, but not go into too much, is the rules for consent are changing, and those changes will come into play around May 2018. So there's an EU-wide organisation called the General Data Protection Regulations, or GDPR, and they're updating their consent guidance, and the UK organisation that represents the UK is the ICO, who've also appeared on this slide, and they've released some draft guidance that the Public Health England have fed into the consultation for that, and we're waiting for the finalised guidance to come out, and that will give us a lot more of a clear idea of what's expected from consent to license. We are waiting on that. The kind of general feedback we've got from it is it will need to be more explicit, and if it does affect consent, then there is an option to go down the route of applying to the confidentiality advisory group, or something called a section 251, which is also known as, and that allows you to process the identifiable information, except without the explicit consent. So if it doesn't quite meet those regulations, it does involve extra work, but it's not a block to get into the data access. It just involves going to apply to the for a section 251 or to the confidentiality advisory group, or CAG, which may slow it down slightly. But yeah, once it's set up and it's running this BiobankLink, the idea is you set up and then you can request data at will, essentially. So hopefully it's worth it at the start to get data access later. So yeah, this next slide essentially summarises what we've been talking about so far, and the other approvals, including research ethics or a HTA license. But also the reason it's the biggest circle there is that your application is the biggest part of it, and it's requesting data for to help you with your research, if it's research or whatever end use it ends up being. That's the bit we're trying to serve. So yeah, we'll do all we can, and that's the priority, to make sure it meets what you're trying to do within your application. So we'll always help where we can to make sure. I think the idea now was to have a quick pause and just go over any questions in terms of those processes now, and then after the questions we'll get into the BiobankLink.
Thank you, Dominic. Yeah, so we just thought we'd have a bit of a break, make sure everyone is still with us. So if anyone's having any issues, or if you have any questions at all, you can message Jessica. So just on the right-hand side of the screen, you can see host, it says Philip Quinlan. Just click there and click on Start Private Chat, and you can message any questions you have to Jessica, aka Phil. But I don't think we have any for the moment, Dominic, so I'll just hand back to you.
Okay. So yeah, the BiobankLink It's essentially what we'd be looking to do would be as biobanks, you could apply to the system once, and that would involve all of the IG processes that I mentioned before. And then once you're set up, you'd be given an ID for all of the samples that you then own, and you can submit that ID into the BiobankLink system, and it will return a set of data that we'll go over later, and would also be useful to have some feedback. So yeah, it would be useful to have some feedback in terms of the data that would be returned to you, and make sure it meets your needs as well. And then you could query that server or link at will. So if you wanted to follow up your patients at any time, you could get the most up-to-date information that the National Cancer Registration Analysis Service has on that patient, and you'd get that just be on a non-secure server, so through the internet around. One question has just come up from before, which was, what is the cost for data? I've spoken to the director for the cancer registration, and initially it won't be a cost. It'll be if you guys can kind of help with the rollout of it, and to help with setting the system up and learning what is the best way for it to work between us and you, then no, that wouldn't involve a cost. So the data you'd be getting free. So going into the BiobankLink project, it works with 7 points, and I'll try not to flick between slides too much, but there's also a data flow diagram for it. So I'll just go through it in points, and then we'll go through the diagram as well, and hopefully that'll clear everything up. So it works in 7 stages. The first one being interested biobank registers by sending information around their collection to NCRAS, which is the Registration Analysis Service. So that involves the consent model, involves research ethics, if that's applicable, HTA licenses, and just make sure that everything's in place for you to receive the data. So once that's done, a registry biobank ID is allocated, and so you as the biobank will have your own biobank ID, and then you will, using that biobank ID, you can send over the NHS number and date of birth of the patients, and what that will allow us to do is to identify the patients in the registry, and then we'll come up with a pseudo ID, pseudonymized ID, a bunch of letters and numbers, that will identify that patient to us and to you, but nobody else. And that's one of the things that list will be kept secure. Once you have that sample ID, so the patient's identified with a pseudo ID, and also that sample is identified with a pseudo ID as well. For instance, if one patient sample, you'd be able to distinguish between the sample we'd be talking about. So they're all returned to the biobank. So at that point, we're good to go. Essentially, we both know who we're talking about in a pseudonymized manner. So we'd be looking to get some information from the biobank, such as material or the cancer site, and we've been working with the UK CRC to mimic the data collection that the UK CRC record, so that you wouldn't be having to reformat the data more than once, and the information that you submit to the UK CRC would be the same as what's submitted to the biobanks, so you wouldn't have to do the same piece of work twice. And then finally, once we have that information, NCRAS or the analysis system can return the data on those samples to you guys, and then you can use it for your research or whatever purpose you were looking to use it for at the first stage. And at that point, that link's set up as well. So at that point, you can query that server at will using the same sample ID, and it will just give you the updated information. So if you want to see if the patient's had any chemotherapy since the last time you queried the system, or if you want to see if they've had radiotherapy, or maybe if they were still alive, you'd be able to do that. So just to recap that really quickly, it starts with the the biobank, and they register by sending data over to us. At the moment, it's outlined as tables, and I've outlined what information would be included in each table in the next 4 slides. But just so you know, the registration by sending table 1 data is your licenses and your consent model and your protocol. So you send that to us, everything's confirmed, and you're given an ID allocation. That's back to the biobank. Once that's set up, table 2 data is sent over in a secure way, as this involves the NHS date of birth, and that goes to a secure server at Public Health England. And then the registry donor ID is allocated, and that's also sent back to the labs. So you'll have a biobank ID and a donor ID. And then it's also sent to OnCall, which is our registry database, which is the server you'd be querying through this non-secure server. And yeah, so essentially we'd know which biobank you are by your registry biobank ID. We'd know which patient it is by the registry donor ID, and we'd also have this sample ID. So we'd know all of that, and it's this sample ID when it goes back to the non-secure system that is used in conjunction with the extra sample data, such as how it's stored, what temperature it's stored at. If I just had a question about if you don't have an NHS ID, that's also fine. If any identifiers are recorded, such as name, postcode, date of birth, we can use another method of matching, which initially we'd look for someone with 4 matches and then 3 matches, and maybe date of diagnosis or something if you guys held that information. So we'd look for other identifiers that could help us find the right patient in the registry database, and once they have been identified in the registry database, we'll go back to using that sample ID. So just to go into a bit more detail in terms of the information that people would be sending across to one another. The original application, which would mimic the ODR process that we spoke about at the beginning of the webinar. The consent details, research ethics approval, detailed protocol, something that will make sure that the data is kept in a safe environment, and also the HTA license. So whilst we're on the topic actually of security assurances, and we'll touch on it more at a later slide. Usually what people use when they apply for data through Public Health England is using an IG toolkit. But one of the things we've heard back from the UKCRC whilst we've been working with them is that not all biobanks have that system set up. So what we do have in that place is a template that we can use to create a system level security policy, which would essentially be a bespoke document that outlines how you would keep the data that is returned to you from the biobank safe. So once the biobank has been registered, we send over the donor information. As mentioned before, this could be NHS number and date of birth, but we could also use other identifiers to find the correct patient. And then the sample information. So once the sample has been, or the patient has been identified in the on-call, which is the registration, then you could submit information on a sample. So we'd know the patient, and then it would also have the material type, the availability from the biobank end, storage temperature, the date it was created, the extraction volume of the sample, and so on down the list. And that would have its own sample ID at that point, and then we'd return clinical information, which at the moment is about 10 fields or 11 fields, or even more. That we could return from the system very quickly, and one of the things that would be useful to hear from you guys would be if you felt these fields met your needs, or if there was anything clearly missing, or if you'd find it useful. And we will follow up with a survey at the end of the webinar. So I think we were going to stop one last time before the end of the webinar, just to see if questions popping up, and then we'll crack on.
Okay, yeah, thank you, Dom. So we've had a question through about consent. Are there any issues with consent which may prevent data from retrospective samples being obtained?
People have struggled in the past. It's a tricky one, really, especially retrospective. When people were consented 10 years ago, the names of all the data controllers had changed. It wasn't something that was routinely used for follow-up in the past, and it wasn't necessarily mentioned in consent. It's a frustration from the research side that I've heard from a lot of people. The issue being is if it's not mentioned in the consent, they've technically not consented to having their information followed up by somebody that's not the biobank, or shared with the research team. And that's the issue, and that's where it kind of gets stuck. I mentioned the confidentiality advisory group earlier, and they can allow it. The other option is if you are still in touch with those patients, you still have contact details for them. Often the easier option may be to reconsent those patients. And the confidentiality advisory group, or CAG, will usually, if you apply to them, as I mentioned earlier, the section 251, they'll usually check to see if reconsenting the patient is feasible. So that should only be used in occasions where it's not feasible to reconsent the patient.
Okay, thank you. We've had one more question. How would data be returned to a biobank if they don't have an N3 network?
The N3 network isn't needed. It's on the non-secure server. So one of the reasons we've restricted the amount of information going would be that nothing is included in it that's kind of explicitly identifiable. So there would still be security assurances that we'd look to make sure the data is being responsibly being held secure, but an N3 network wouldn't be necessitated. The only time we'd need a secure network to exchange information would be when we're swapping the NHS numbers or the identifiers at the beginning of the process. And again, an N3 network isn't needed. The ODR have a secure file transfer system that we could use, which would sign you up on that system and give you an account, and we could use that to swap the identifiers.
Okay, thank you. Can we do another poll?
Jessica was just saying we had one last
question. Have you got it?
No, sorry, it was there was just a complication here. Someone was asking about the date and cause of death, which we spoke about earlier. Was you could apply for from OND. The extra stuff they're asking for was transplant date and an outcome as well. In terms of getting that information, that would be the transplant date would likely be found in the hospital episode statistics, which is controlled by NHS Digital. So I think with a question like that, because you're asking for outcome data, that may be something that's also held by NCRAS. So that data will be held across 3 different data controllers. It is possible, but it may just involve a bit of extra discussion to work out who would be the best person to apply to.
Okay, great, thank you. I think we just have one more question here. So non-generalized information such as morphology, grade, etc., how will the system deal with a patient having more than one cancer episode?
We would have to link the sample to the correct, to the initial diagnosis to that diagnosis of cancer, if that makes sense. So if they had a second primary tumour, we'd probably use the date that it was extraction procedure, the extraction site, and try to link it to the correct diagnosis.
Okay, we have another couple of questions. So do all the people using the data need to be known by you? It depends. So that would depend on the consent.
sometimes the consent model may say, and this is where consent can be really powerful to help you access data, but can also restrict how much you can do with it. So if the consent is nice and broad and it says we may share this information with research teams, so on and so forth, we wouldn't need to know that information, because who are we to go against the information, the process that consented to? It's their data at the end of the day. We may need to know who has access to the system if it's purely kept within your biobank, not by name, but just as long as there's a person responsible for the system, that should be fine. And then we just need to be aware.
Okay, and then one more. Is it possible to just link the donors rather than the donors and all the samples?
And get patient level data back? Yeah, that would be possible.
Okay, great. Well, I don't think we've got any more questions, so we've got another poll to finish up with. And then, of course, if anyone has, okay, so here's the poll. Do you struggle obtaining clinical data on the samples you hold? Oh, okay, it's moved on. How will the BiobankLink process affect the data you acquire? So will it make no difference or speed up acquiring data you can already access? Or will it allow you to access data that you can't already access? I think that's almost everyone that's responded now. That's really good. That's quite positive. So, I mean, if anyone has any further questions, you can always message us after the webinar. Thank you for everyone for logging in. Thank you for Dominic for participating in the guest webinar. Just to let everyone know that we have recorded this, so it will be on YouTube and on our website if you want to refer to it later. If webinars aren't your thing, we are planning to have our annual meeting on the 18th of October this year. It's called UK Biobanking Showcase. We're actually featuring a talk on the GDPR, which Dominic mentioned earlier. And so there'll be more information online about this programme. So you can see that on the screen, I think, at the moment. So we are also interested in running more webinars in the future. So if there's any topics you're interested in, just let us know. You can get in touch with us via the email contact@biobankinguk.org, and we're on Twitter @biobankinguk. So if you've got any feedback on the webinar, any ideas for future stuff, just get in touch. And thank you. Thanks, Dominic. Bye.
Thank you. Bye, everyone.